Hello, my name is Donella Fields. I'm a registered nurse and BSN student with Liberty University in Lynchburg, Virginia. In this presentation, I will be discussing a race against time. You are going to see that our First Lady of Nursing, Florence Nightingale, has implemented changes and found discoveries that have caused us to change the way that we do nursing today. And along with this current pandemic we find ourselves in, what she discovered is highly relevant to what we do today. I hope you enjoy the presentation. Evidence-based practice during COVID-19. What does that mean and what does it look like? Evidence-based practice is the collection of information and research that helps us implement changes directly as a result of the information that we have found. As medical providers, as nurses, doctors, and ancillary medical staff, we find this information and then we implement them into our practice, which of course improves patient outcomes, which is exactly what we all desire to do. So we're going to figure out what patient outcomes we have improved over time and how important and relevant they are today in ending COVID-19 and trying to get out of this pandemic we find ourselves in. And you're going to be surprised that most of the knowledge that we already had works, but we're going back to basics. The technology that we use these days, talking about practical applications such as Zoom and Google Meet and ways for us to discuss healthcare with our patients and have online video visits and phone calls with our healthcare providers is fantastic. But that doesn't help us stop COVID-19. What is helping us begin to eradicate this virus essentially started with Florence Nightingale. And we're going to see how and we're going to see why. This is Florence Nightingale. She was an environmental theorist. She was the First Lady of Nursing. She considered nursing to be her divine purpose. She emphasized nursing as a calling. Now, Florence Nightingale grew up in the affluent society. Her mother came from a family of merchants, and her father acquired 2 estates from his family, one in which Florence lived in, and she became a lady of stature. They were in their social societies, and she was to marry a man who was suitable to be her suitor. Florence Nightingale was quite stubborn, and she volunteered. She was always a philanthropist, and when she turned to her teenage years and became a teenager, she realized in her philanthropy that nursing was her calling. Nursing was something that she wanted to do, and she did it without the support of her parents. During the Crimean War, she implemented her nursing skills, her knowledge, and the way that she took care of patients and made some changes that we still implement today. So here's why. When Florence Nightingale, she would walk around the ward for these Crimean soldiers who were lying there. I mean, you can just imagine it's pitch black. You've got these makeshift cots and floors that these soldiers with wounds are laying on. You can hear the moaning. You can smell the death and the disease. And there's Florence Nightingale, this tiny little young girl with her little lamp illuminating the surroundings, trying to take care of these soldiers. What she realized was most of the soldiers in the care for the Crimean War were not dying because of their wounds. They were dying because of disease, because of typhoid, because of cholera. How did she come up with this? Well, Florence Nightingale became a statistician. I can never say that word, a statistician. She implemented statistics, essentially. With the support of Queen Victoria, she created a Nightingale Rose diagram, which basically showed a way to decrease the death rate from infection. These statistics showed that there was 18,000 soldiers that had died during the Crimean War era. 18,000. 16,000 of those men died from infection. That's astounding. If they died from infection, we now know that is preventable death. Absolutely preventable death. It became Florence Nightingale's mission to figure out how to fix that. How can she save lives? What is it that we can do? What is it that's causing this infection? What is it that's causing us to aid in the death of our patients? She collected data. She did her own evidence-based practice. And what she found was the water was dirty. Hand hygiene was not being performed and would help. The way and the time frame in which bandages were applied and removed and changed, how the wounds were being cleaned, how to separate one person from another. All of the things sound very familiar to us today because these are things that we're learning we need to re-implement to COVID-19. Now, don't get me wrong. I'm not saying that through nursing, we've never done these things. We have been. We've been doing them for years. But maybe we've become a little lackadaisical. How do I mean by that? Let's think about different social structures. For example, some countries, when they greet you, they give you a kiss on both sides of your cheek. When other cultures get together, the first thing they do is say, "Oh my gosh, hello, it's nice to see you," and you give each other a hug. There's always a lot of touching involved in the human race. It's something that we've grown to need, we desire it, and we thrive on it. Unfortunately, because of the COVID-19 pandemic and the way that this virus spreads, we've had to step back. We've had to step back and not touch each other. We've had to keep our distance. We've had to stop the amount of time that we have had to spend with each other because of the way that this virus grows and spreads. This is something that the environmental theory by Florence Nightingale came through years ago, 100 years ago, if not more. And now we're taking those basics, we're taking our research, and we are now implementing them again. This is how we know what love is. Jesus Christ laid his life for us, and we ought to lay down our lives for our brothers and sisters. 1 John 3:16. This, I believe, is what Florence Nightingale based her practice on. She wasn't worried about herself. She wasn't worried about whether or not her parents agreed with her. She felt it was her calling and her divine purpose to help these soldiers, and she did. At the risk of her own health and safety, she went in full force, and she didn't only do the job of a nurse, but she did the job of the statistician, and she did the researching, and she did all of the things that she needed to do in order to help us many, many years later. Quite the hero. Let's talk about the nursing meta paradigms. We have nurse, patient, environment, and healthcare. And before we start, 2 Chronicles 15:7 says, "But as for you, be strong and do not give up. Your work will be rewarded." How true is that? How many nurses have gotten themselves dirty, covered with things that we shouldn't be covered with, and we're okay with it. We're okay with it because we know that we have to go through these things to get the best outcomes for our patient. Sometimes we don't do and worry about ourselves. We worry about our patients first. We worry about us last. And it can be a thankless job. It can be exhausting, but we will be rewarded for what we do. We will be rewarded for what we do. All right, so with COVID-19 creating havoc on the human race, healthcare professionals have been faced with many, many challenges in discovering how to contain and eradicate the virus. Nurses have been on the front lines fighting to help establish the appropriate tools needed to abolish this crisis. Using proper hygiene and donning the appropriate PPE, your personal protective equipment, has been instrumental in diminishing the virus's chance of spreading. When PPP was at an all-time low, The nurses had to become creative, designing barriers to protect themselves and others from the COVID-19 virus. I don't know if you remember, but in New York, you saw nurses wearing garbage bags because they didn't have gowns. They had to do what they could so they could stay on the front line, they could stay beside their patient's bedside, they could keep those patients alive and give them care, but trying to implement safety for themselves, overcoming obstacles on a daily, minute-by-minute basis through the COVID-19 virus. This has had a direct result on the patient outcomes seen in the facilities within our local communities. Initially, the virus was winning as it moved through the air, targeting any human within reach. Through the course of trial and error, repeated research, clinical documentation, and the spread of this disease became more easily understood. Nurses are pivotal in understanding COVID-19. They are there. They see it, they feel it, they live it, they breathe it. And most of them at this point have had it. They have been able to take their experiences and that data and help put together evidence-based practice that is helping us move forward. This is helping us to lead to more appropriate care for our patient. Our nurses are able to educate our communities on proper hand hygiene, washing surfaces and disinfecting them, donning face masks, and of course social distancing, isolation, quarantining, and what all of these things mean. And as a result, finally, we are starting to slow the spread of COVID-19. Finally. And if you compare continents and countries, you're going to see that some are being more successful than others. And why is that? Because some countries aren't implementing as quickly. Some countries are having a harder time getting the vaccine out. Other countries, aren't practicing the hygiene that they need and the social distancing that they need. And that's not helping. So we have to try to figure out a way to make the changes, show this evidence-based practice, and get it through to the whole world so that we can do this as a team, a united team. All right, so our environment has changed greatly. All we have to do is look around us. There are signs everywhere reminding us to wear a face mask and practice social distancing. Any facility, medical or otherwise, that you enter, grocery stores, anything, houses hand sanitization stations and have reformatted the floor layout to keep the public distant. In many cases, barriers have been put in place separating the public from the frontline workers. Employees are on site to clean and sanitize grocery carts, toilets, and many other tools used by so many daily. These measures have impacted healthcare and the way that we live. Greater care is given between patients to not spread germs. Families and loved ones of those hospitalized, they can't visit anymore, leaving these patients feeling hopeless and feeling alone and afraid. Can you imagine being in the hospital, a victim of a pandemic, with no information other than what we currently know? There's no history, there's no long-term data, long-term research to determine how our personal outcome is going to be from this pandemic. And then having to go it alone because you're lying in a bed in a hospital and your family can't visit you. Because you're on isolation, the nurses aren't coming to the bedside every 5 minutes and checking on you. They're staying away as much as possible to keep you and them safe. And, you are now fearful. You are now afraid. Our psyche is changing through this pandemic. People are becoming depressed. People are becoming suicidal. This pandemic has had so many effects on all of us. For a variety of reasons, and our jobs no longer feel thankless or taken for granted. Nurses are now admired and recognized as the heroes they have always been. Because when you see a nurse with a patient who is dying from COVID and there is no turning back, those nurses are holding that patient's hand. They are by the bedside. They are not letting go. Regardless of the effect it may have on them long term, they're there for their patients. Now, we all know that nurses have been doing this for a very, very long time. However, the public is now seeing what the nurses are doing. And that has made a difference. Our current practice is definitely different than it used to be. One difference is medication administration. When I grew up as a nurse, if you didn't draw a medication up, you didn't administer it. That's just the way that it was going to be. Now, we have mass vaccination clinics everywhere. I mean, you've got vaccination clinics that are vaccinating over 1,000 people a day. You can't draw up all of the medicine, jab all the patients, do the pre-screening, do the health history, and give them this in a timely manner to get 1,000 people through one room in an 8-hour period. You can't do it. So the way that we get through this is we have stations. You have a nurse drawing up the vaccine, jotting down the lot number and all of the information, and you have somebody else distributing it to the nurses, and the nurses are administering it. This is the only way we can get through mass vaccination. This is something that we would never have done 2 years ago. It just would never have happened. Another difference is that we no longer hug and hold our patients as much as we used to. We used to hug and hold our patients, goodness me, all the time as a matter of course. You'd go into your patient's room, you'd hold their hand, you'd sit there, you'd wipe their brow, you would do all of these things for them, because caring and personal touch can sometimes be the difference between life and death. It can be the difference between dying alone and dying in peace. It can be the difference between being a nurse and not being a nurse. But of course, to the spread of COVID-19, we can't do that because those who are afflicted aren't getting as much interaction from staff as they normally would. I've seen this time and time and time again. You take a patient who suffers from anxiety and depression, and you put them in an isolation room with COVID-19, and they're not allowed to have any visitors. They're not allowed to have the staff coming in on a regular basis. They're coming in, maybe once every 4 hours. And now you've got somebody who's lying there depressed and anxious and feeling afraid. And all we're doing is adding to those emotions, adding to that fear. And we're learning from this. We're learning how to figure this out. And technology has been a big part of that. Being able to do FaceTime with the patients and being able to speak to people on the phone, being able to give them the technology that they need so that they can reach out to their family members and spend the day on camera with their family, watching their grandchildren run around and play. The way that we do nursing has changed, and these poor patients of ours, they need us and they need us to be there. I'm sorry, this is just, it's a lot. I spoke to a patient not that long ago on the phone, and the poor thing, he was absolutely gutted. He was so terrified. He had been married for 60 some years, and he'd never spent a night alone without his wife. They were separated due to COVID-19 and his hospitalization, and she was at home by herself. And he suffered from anxiety. And even with the medication they were giving him to help, he was still laying there afraid. And I think that somebody that's in their 70s and 80s shouldn't have to live a life in fear, and they shouldn't have to worry about whether or not they're going to live the next day. This has been really horrible for everybody involved, and I'm just so proud of our nurses and the things that they have had to overcome to help their patients. So our current practice doesn't allow us to touch our patients as much as we would used to. We've implemented mass vaccination clinics. We've had to implement social distancing, and the CDC guidelines now say 6 feet or greater for an accumulative 15-minute period within a 24-hour period. Visitors are not allowed, and we wear PPE as a matter of course now, not just because we've gone into an isolation room with somebody who may have C. diff or MRSA. This is every patient we need to be careful of now. Our plan of action assessment. Let's see. Assessment and triaging of patients has changed drastically through the life of the pandemic. The internet and access to technology has been imperative for most families to receive medical care they need and for their PCPs to assess and treat them. This has been a more recent development for the nursing staff as well, as it has expanded the way we communicate when we are isolated and how we can care for our patients without being hands-on. There have been many developments that have led to the improvement of the way we do things, such as donning and doffing PPE. We've had to become creative in our education techniques to the public as a whole and translating COVID-19 into a layman's terms so our communities can grasp the concept of what they have, what we are dealing with, and how to protect themselves. Empathy has become a much greater part of our care than ever before. Our communities are emotionally exhausted. They live with the guilt that they weren't at the bedside of a loved one who has passed away. Trips have been cancelled, graduations cancelled, and schools have been placed on hold. All of the activities and special occasions we have been accustomed to celebrating have become a thing of the past. We have changed the way that we do our screening. We screen people online. We ask them screening questionnaires before we even see them. We triage via the phone in a more thorough and elongated manner. And we have had to improve the way that we educate our patients. And even people that are not patients and are not sick, we've had to educate to the masses instead of to those that come in front of us daily. Everything we do, whether we are on the clock or off the clock, has been education based for the last year and a half. Every single person you talk to wants to know what they should and should not be doing to protect themselves from COVID-19. Every conversation we've had for a year and a half has been COVID-19. We have had more power in the last year and a half of our careers to spread empathy, education, and understanding to our societies, our communities, and to our world than we've ever had. We have to look at our SMART goals. Establishing SMART goals for the healthcare workers is of paramount importance to eradicating COVID-19 and returning to our new normal life. Our specific goals include the rapid identification of suspected COVID cases. We must utilize the measurable data, keeping count of the areas involved both geographically and demographically. This is inclusive of isolating the positive and probable cases per the CDC guidelines, implementing lockdowns as necessary when needed. Realistically, we have to ensure mass vaccination clinics and the immediate rollout of vaccines when they become available. This is an ongoing issue as certain areas have had shortages. Our trackable date includes our case count, death rate, hospitalizations, and demographic information. In order for any of this to work, we must evaluate our progress. We have to monitor the case counts and declines within the community and around the world. Interviewing the frontline workers about their struggles that they have faced and continue to face whilst caring for this population is paramount for us to learn from this and to be more efficiently and effectively prepared for if this ever happens again in the future. Implementing these findings will aid in published research to help others slow the transmission of the COVID-19 virus. When we collect data for COVID-19, we put these in our theories, our COVID-19 theories. We've got to share this information. We have a responsibility as nurses in the nursing field. We have a responsibility to share the things that we have learned. We have to share this information to help protect, eradicate, and prevent this from happening again. I implore upon you from one registered nurse to the next to do your very best, to be diligent in all that you do, trust your instincts, and share your knowledge. Be a leader, not a follower. I hope that you have enjoyed this presentation, and I thank you for taking the time with me today to learn about COVID-19 and our theory. Thank you. Bye-bye.